Maya, Dr. Tenzing is here,
Yes.
and I want to introduce him to the group.
Yes.
Dr. Tenzing, are you, let me see, Tashi, can you turn on your video and your speaker? Perfect. So Dr. Tenzing is basically the founder of the embryonic trauma program in the Kingdom of Bhutan, which myself and one of my residents who is from Bhutan, Dr. Giri, were over there this past December. We're helping to collaborate trauma education training in Bhutan, and Dr. Tenzing is a neurosurgeon, a very accomplished surgeon and great vision for his country. It's one of the most beautiful places in the whole world. And as you all know, it's known as what they're interested in is not gross domestic product, but gross domestic happiness. So everyone can welcome Dr. Tenzing to the group.
Thank you, Professor Hendrik, for introduction.
Dr. Ginsburg, my trauma program director, Sandy Arabian, who is in the call, was helping Bhutan establish the first trauma register there a few years ago.
Excellent, excellent. We're in the process of working with them and sort of fusing that for a more reasonable one. Dr. Tenzing, would you like to say any words?
Thank you, Professor Hendrik, and everyone on this Zoom meeting, and all the good well-wishers for Bhutan. I'm actually excited to join with the trauma. My residents probably are joining as well. Can you hear me?
Yes.
Yeah, so
yes, very good.
I'm basically, with regards to trauma, we have been sort of exposed to American College of Surgeons through ATLS. So we are following in the similar sort of a system. The ministry had just came to me for setting up and assessing all the trauma centers which were earmarked. So we will be taking your help, Professor Hendrik. I think whatever you have done in a very short time, this will go a long way. So we will probably be working together. And I'm so grateful for allowing me to participate in your International Trauma Zoom meeting. And we look forward to sort of get guidance from you all. So with this, thank you very much and all the best.
Welcome to the group, Doctor.
Dr. Ginsburg, you're muted. I can't hear you.
Dr. Tenzing, the person who is who's giving the case report today is one of our fellows who graduated from our program and is now the director of trauma at the busiest trauma center in Jerusalem. So and you've got some of the greats like Aurelio Rodriguez, as well as Dr. Kasim, Dr. Utrecht, everyone who's on this call, Hochman, as he's helped already with registry. So hopefully we can help you as you need in developing your trauma system. Thank you, Maya, and thank you, group, for letting me just introduce Dr. Tenzing.
Of course, it's a pleasure, Dr. Ginsburg. So I think it's 8:05 and we can start. So good morning, everyone, and welcome to today's session of the Tele Trauma Grand Rounds. So today we have Dr. Alon Schwartz, who is the Director of Trauma at Shaare Zedek Medical Center at Jerusalem, Israel, presenting a case about blunt pelvic injury. So over to you, Dr. Schwartz, to continue with the case.
Thank you, Maya, and welcome, Dr. Tenzing. It's an honor for me to present a case every time again in this forum and the conference. I chose a case which is a blunt pelvic trauma, but we may have a few challenges on this case. So let's start. So this is one second. Okay. Okay, so this is a 63-year-old male. Came to us after 30 minutes from the injury. The mechanism was a metal fence that fell on him on the pelvis while walking in the street. They took the EMS team time to extract him under the fence. He was basically stable with heart rate of 80, blood pressure of 140/85, and O2 saturation of 95 in room air. He just was transferred on backboard and just got some analgesics as a treatment. So in the trauma resus, had no airway problems. He was talking. On B, bilateral clear breath sounds. No need for intervention. Circulation, so he had the heart rate of 90. Blood pressure a little lower than was presented by the EMS, but still stable. And he was pale with no sweating. He was the GCS 15 and moved all 4 of his extremities. And on exam, he had a suprapubic tenderness with suspected blood in the meatus. EFAST was negative. This is his chest X-ray, which was with no findings. And the pelvic X-ray looked like this. This is venous blood gas. You see he's pretty much stable with pH of 7.38, bicarb 25, and lactate 2.6, which is a little high, but not that high. 1.9 or 8 is fine, so he's a little high. But bicarb 25, PCO2 43, so pretty much stable. On this moment, I want to ask if anybody would do something. So I will transfer Maya the question to probably if we have residents here, what would they do?
Thank you, Dr. Schwartz. Dr. Anchak, would you like to make your comments first?
Certainly so. He's got an open book fracture with sacroiliac joint, and he's totally stable. You talked about possibly blood at the meatus, but a negative EFAST. And on the EFAST, if it's negative, you probably would have been able to see the prostate. If it's a normal position, not floating, then that's the same better information than you would get from doing a rectal exam, and this now a trend toward eliminating the rectal exam for some pelvic trauma. I would you have 2 IVs and blood sample to the blood bank if you need it. In this case, I would look for signs of an open fracture, and which would include a rectal exam anyway. And assuming it's negative, go ahead, try to put a Foley catheter in. And then I would also, because of the opening of the open book nature of the fracture, put a pelvic binder on to prevent development of hypotension.
So if I try to understand, you will do a rectal exam, and according to that, you will decide if to put Foley in or not.
Well, the patient is stable, and I would do on the fast exam, look for the prostate. You can see it very well, and if it's up, way up in the pelvis, then then I would not put a Foley in. But if the prostate is in the normal position, I would make one attempt to see if a Foley would pass easily without worrying about the rectal exam. I think for pelvic fractures, to look for signs of an open fracture, at some point, it's once the patient is stable, it's a good idea to do a rectal exam, and women a pelvic exam to rule out blood in the rectum or the vagina. But in this, before putting in the Foley, if you see the prostate in its normal location, that's better information than you can get from a rectal exam to assess whether there's a urethral injury.
Okay, thank you.
Mm-hmm.
Thank you, Dr. Anchak. Dr. Kasim, are you with us? Can you hear me, Dr. Kasim? Okay, Dr. Hodgman, would you like to make any comments?
Sure, thank you. Well, this is, I will follow the ABCs in this case. You did this, and now you know that he has a pelvic fracture. He's hemodynamically stable. So the things that need to be ruled out here, particularly is the concern of blood in the meatus, is either urethral injury or a bladder injury. And obviously in this type of fractures, a rectal injury needs to be ruled out too. So yes, I will do the rectal exam. I know that people tend to think about that not being necessary, but I would do a rectal exam first, looking for a high-riding prostate. And secondly, looking for blood. Blood is looking for blood. If we find it, we confirm a rectal injury. If we don't find it, we're still not sure. And if he has not a high-riding prostate, I would put a Foley catheter. And I will do that because I would like to see if there is blood in the urine, because that will indicate probably a bladder injury. This patient here probably will have come with, this appears to be more like a vertical tear injury than an open book, because both iliac wings are kind of like a different level, and the iliac joint on the left is wide open, but it could be that it's the way that the x-ray was taken. Having said that, this patient most likely here will have arrived with a pelvic binder, and we will keep the pelvic binder in place. And I probably will get another x-ray before deciding to put the pelvic binder here. Maybe this is really an open book. It's difficult to say from this x-ray, but it's possible that I might need a pelvic binder. And after that, I need to go for a CT scan. This patient needs to scan. It's hemodynamically stable, needs to be scanned. If by any chance in this process he becomes hemodynamically unstable, and you have a negative FAS, I will probably alert IR, and maybe in the way to IR, do a preperitoneal pelvic packing, or hopefully not, and can go to IR before I have to do anything. Thank you.
Okay, we will reach the hemodynamic instability, but according to Foley, you will put a Foley in the trauma bay with this information or not?
So if the prostate, if I don't see blood in the meatus and the prostate is not mobile, yes, I will put the Foley.
Thank you.
Thank you, Dr. Hodgman. Dr. Rodriguez, would you like to make any comments?
Yeah, it's a very interesting case. Excuse me. Couple comments. Number one, I am glad that somebody used the physical examination to look at least the penis, because bladder meatus is an injury urogenital and the proof otherwise. Okay. Second, rectal exam, very important. Okay. 3, see they have a other scratch in the side of the pelvis. All the physical examination. It still is open, the physical examination. Okay. Now since I published the sonography, you call it echo fast, in 1990, 2 years before Rosicky, you know, I was not aware that you can, maybe the technology has advanced so much that you can see the prostate. We just used it to see if it was fluid or not in the belly, but I don't know. I don't know how to see the prostate, either it's up or below. So good, that good that you can see the prostate. I don't know, you say that, somebody said that uses the echo to see the prostate is floating or not. Number 3, and you read the literature, they say that the pelvis X-ray and this classification of Burgess for shock trauma and the other classification of the Wesleys of the ring, the pelvis fractures, not necessarily has to do with mortality, right? Has to do maybe in some way give you some ideas what you're going to do, but it's not as much important. Everybody's paying attention to open book or closed book, in the middle book, all that stuff. Perhaps some of these type of fractures has to do more than mortality, has to do with the amount of transfusion the patient is going to require, according to the literature, more than predicted mortality or what you're going to do. But anyway, that's important. I think everybody's right, except that it was another commentary. Oh, I always teach, because that's the way we did. Before putting the Foley, we do a urethrogram, you know, and then there's 10 centimeters, 10 cc's of a contrast, and or 20, depends who you deal with, or the urethra and see if there is a urethral injury before put the Foley all the way in, you know? So I don't know.
You do it in the trauma bay, not in the radiology suite. You
yeah,
do it
that's
in
right.
the trauma bay.
Yeah, the trauma bay. That take a few minutes to put some contrast, shoot, and they see how the urethra is, you know, and see, and then you detain, because you can do a lot of damage trying to put a Foley, can be in the wrong passage or something like that. That's what I knew. Now they have changed. You guys are more aggressive to put out the Foley. That's it.
Thank you. Okay, I think we will go on with the case. We will have more challenges. So, second.
Alon, before you go, I'm from the school of Dr. Aurelio Rodriguez. Blood at the meatus, you do not put a Foley in to create a false track in the urethra. And you can have it done in the trauma bay or in radiology, since he is going to CT scan. As to the butt binder, if he's stable, I think I'd like to put it in, but it's only going to work in those patients that have a true expansion of the pelvis, allowing blood to accumulate.
Okay, so I am from your school, so we probably did the same. We place a pelvic binder, we put no Foley in, and we went to a CT scan with urology that they will perform, because in our hospital you have to involve everybody unless they will get insulted. So we have to call urology to do the ureterogram. We took the blood with us since he was a little bit pale and his blood pressure wasn't the best. We took blood units together with us to the CT suite. And this is the CT. This is just the arterial phase. So you see the chest is completely fine. All the injury was in the lower abdomen or pelvis. And you can see, 1 second, we had a problem here. For some reason it stopped. Now, 1 second. Okay. I will have to open the presentation again. So 1 second. Give me a second. No, it's not this presentation. This is a different one. Okay. default. מקווה שלא סגרתי את הזום. תרגיל. תרגיל, עכשיו הכל בסדר. This is it, no? Share. Okay, you're back. לא, זה לא זה, אבל... Do you see the presentation now?
We see the CT.
Yes.
That for some reason it doesn't. 1 second. נסגור את זה.
Can I make a comment when you're working on that so people look at it? When you do a CT or a scan, in this case, you do a regular CT or use a CT with contrast, obviously, but they use something for the bladder, like it's like it have a different name. I think when you do you suspicious
CT cystogram.
That's it. That's it. That's what's done. I don't know.
While
It would be part of the workup, Aurelio, I agree. If you're going to CT, you might as well rule out bladder injury with a CT cystogram along with the CT angiogram.
While Dr. Schwartz is working on the presentation, Dr. Tenzin,
Yeah.
do you have any comments? Would you like to add something?
Okay, you see it now, or you see it in a view, in a
We
presenter view?
see your
We see-
x-rays.
You have to switch the screens.
We see it in a presentation form.
Okay, 1 second. Probably not this. זה גם לא, נראה לי שנייה אני אוציא את
It's
זה
on the top. You have to go to the top. Have a switch this place on the top. Just press the arrow that says back, and after that you have to switch the place on the top.
Okay,
There.
now we're good. Okay, so now we're good.
It's your
Yes.
presentation.
Yeah, we are seeing the presentation correctly.
Okay, good. So we'll skip I'll just show you the reconstruction. So this is the X-ray. This is the CT, the reconstruction of the pelvis. So you see the pelvis ring is broken like the pubic rami. And you see also the sacroiliac joint and the iliac crest is completely destroyed from both sides. Yeah, you see the sacroiliac joint from the left side is separated, from the right side is completely destroyed, also with the iliac crest. And on the left side, you see the pubic rami open. And this is before we did the cystography. You see hematoma, extraperitoneal, basically. And after the cystography was done, like the urethrography, you see no leak from the urethra, but just a leak from a big hole in the bladder. And in the bladder, you see also blood clots. In the CT screen, the patient deteriorated hemodynamically. Blood pressure went down. After we placed the Foley, fresh blood began to come from the Foley, like about 1 liter of fresh blood, and we started transfusion in the CT scan because we had the blood with us. So he received 2 units of packed blood cells. With the partially responder, his heart rate became 100 and blood pressure 95/40. So right now we're in the CT scan and we have to decide what's next. We send another blood gas. We had time to check this. So you see that the patient deteriorates. His pH now is 7.28, and his lactate went up to 4. Patient is still not intubated, and you see this is like 1 hour from arrival, because until we went to the CT scan, we performed the cystography. So this is these 2 exams, these 2 venous blood gas are 1 hour in apart. So what next? And should we go to angiography straight from there? Should we go to the OR and then do what? Do pelvic packing, do laparotomy, X-fix, other ideas? That's the question that I address you.
Thank you, Dr. Schwartz. Dr. Hodgman, would you want to make your comments first?
Sure. Well, a few things. This patient, look at the DBG, he has a mixed acidosis, he's retaining CO2. And also the lactic acidosis is worse. So this patient, considering I have no problems in the chest, I will intubate and take that out of the equation. That will help me normalize the pH. I can hyperventilate if necessary. And after that is what to do with the pelvis. It appears to me, based on that CT scan, that this patient is probably bleeding into the bladder. And that's really very problematic. It wasn't bleeding until you put the Foley in. And now with the Foley in, it started to bleed. To control the bleeding coming into the bladder is kind of very difficult. I would probably try to, yeah, you see contrast there, but it's not clear if this contrast is all coming from the bladder or is coming also from the angiogram that he got before. So I would probably go to the CTA first, or angio first, sorry, angio first, and see if there is anything that can be embolized. I will this is the time I will involve urology here because they might need to do a cystogram, a CT, look with the camera inside the bladder and see if it's anything that can be cauterized in the mucosa if the mucosa is bleeding. But this is a very difficult situation here because you need to determine where the bleeding is coming from. If it's coming from some injury in the bladder itself, it's at the level of the trigonus, is where the ureter and the ureters and the urethra come very close together. Very difficult area. If you need to do this open, you need to open the dome of the bladder and try to fix it without causing a stricture in any of those three openings. So it's really a bad situation. So in summary, I will probably clamp the Foley. I will go to angiogram and I will get urology involved to take a look inside the bladder. Thank you.
Thank you, Dr. Hodgman. Dr. Kasim, are you with us? Can you hear me?
Can you hear me?
Yes, we can.
My
like to
video
make
is
any
not
comment?
working, so bear with me. So looking at the reproduction CT on the film, this looks like a massive injury to the pelvis with an obvious injury to the bladder. And both the ureters are intact as far as I can see, and there is no injury to the kidney itself. Now, the catch here is the patient started to bleed rather profusely after the Foley went in and when the transfusion was started. So I have to assume that he's bleeding from the bladder. And when you're bleeding from the bladder, a cystoscopy is not going to be very helpful because everything will be a bloody mess. So in my opinion, cystoscopy is out. As a surgeon, this is my thought, I don't know what the urologists are going to say. When something is bleeding so profusely, you need to make an attempt to stop it because blood loss is blood loss. You have to accept that. So I think I probably would take him to the operating room and have a look inside the bladder to see what is bleeding and stop the bleed first. That's my first thought. Thank you.
Thank you, Dr. Kasim. Dr. Untract, would you like to make your comments?
Yeah, yes, just rather interesting. It's a great case. So the way it looks on those images you have there, you have a hematoma, but it's anteriorly in the pelvis around the bladder, not by the sacroiliac joints. It's really anterior bleeding from the pubic fracture, which looks like that it could have injured the blood, it could have perforated the bladder or caused bleeding around the bladder. So I certainly call the urologist, see what he said, but I would be inclined first to go firstly to angio if it's readily convenient. If you have a hybrid room, go there. And then the issue about if the bladder is injured, then it looks to be like an extraperitoneal injury because you don't have contrast freely floating, at least on the scans that I can see, into the peritoneal cavity. So it's an extraperitoneal bladder injury. And whether you would call that in the setting of a pelvic fracture, whether you would call that an open fracture, I don't know, because the bladder's sterile. It's not into the rectum. It's an open fracture. It's contaminated to the back, but in this case, I don't know if you would classify it the same way. And then about the fast exam, it couldn't have been a fast exam. It's hard to believe that big hematoma just accumulated after you did the ultrasound, but that should have shown the classic bow tie sign or a half bow tie sign around the bladder that should have been obvious. And also, it looks like based on the position and your ability to put the Foley in without difficulty, that the neck of the bladder and the prostate would have been at the proper location. Doesn't seem to be a big hematoma around the bladder outlet, but more laterally on to the left of the bladder. So rather interesting. But the decision whether to go to angio, I would be inclined, if you gave him blood and did to go to angio, find the bleeder, stop the bleeder, and then ask the urologist, okay, what do we need to do here? Open a bladder and but get his opinion. But for stopping the bleeding, I think angio is a good possibility in this case.
My flight's about to go, and I wanted to make a comment on this.
Sure.
This is a super interesting case. It's usually extraperitoneal bladders you don't have to operate on, but in this case, I think you're going to need to. What I would do is bring this patient to the OR, and then set up my IR people. We have a sort of a hybrid. It's not truly a hybrid, but have them available to come in. After I would do a very small upper midline incision, make sure there's no intraperitoneal bleeding, because even a CT can be wrong. And if just a small incision, make sure there's no intraperitoneal bleeding. Then what I've been thinking about is, instead of doing a lower midline to get to that extraperitoneal bladder rupture, I'm thinking what you could actually do, sort of like with packing, because it could be a combined pelvis and bladder, do kind of and I just thought about this now, is sort of make a very low fan and steel type of incision, which allows you to pack on both sides of the pelvis, like pelvic packing, but can also get you to the anterior up again, the retropubic space, so that you can repair the bladder and stop the bleeding. If there's still bleeding going on with packing afterwards, or you can pack and then get the IR people to angio and the OR. And I'm about to take off, but great case.
Just before you take off, I will tell you that we did what you wanted, but since the CT scan didn't show any peritoneal free fluid, so we didn't open the peritoneum, and let's see what happened. But we went just extraperitoneal, so we did like under the umbilicus incision, we went just extraperitoneal. And actually, can we continue, Maya?
Yes, Dr. Schwartz.
Can I make a comment before you continue? I
Yes,
understand the rationale for going extraperitoneal, but maybe I had bad luck, but I've been there, done that, and the hematoma, there is no planes. It's very, very difficult to find. You've seen the bladder is there, but it's very, very difficult to find, and it's even more difficult to close at the end of the case. So I personally would have gone intraperitoneal. I'm not saying that it's wrong to do this approach, but I just a word of caution about going extraperitoneal.
I think eventually, I've had a couple of these. I've had a couple of these cases where you can open the dome, like you were saying, but then I had to, literally, it's dissected away from the pubis, so you can close it at that time. I've got to go. Bye-bye.
Have a nice trip, doctor.
Okay, so we chose to go extraperitoneal.
Can I make a comment before you continue?
Sure.
One concept, I'm sure there is no resident because the slaves are working, they are not there listening to this conversation, but maybe they listen later. Okay, 80% to 90% of the bleeding and pelvis injuries are venous, and not arterial. Okay, we have to concept that. So angiogram is necessary in this case because of the history. But this patient, there is no blush that I can see. Second point, it is very important what everybody said, that when you have bladder rupture, there's two possibilities in CAT scan. Flames, the blood go around. This is extraperitoneal. Treatment for extraperitoneal normally is just a Foley, okay? unless the patient is hemodynamically stable like it is. This is another story. If it's in between the loops, that's intraperitoneal, has to be operated. So extraperitoneal, intraperitoneal. It's a different approach. A, B, C, D. Okay, then you start all these phantasmagoric things that we're saying. But anyway, so in this case, everybody, we all agree. I don't think, especially now it's a shock, isn't it? The pressure drop and everything else. So I don't know the extraperitoneal, unless you're very good. I never did this extraperitoneal anything. I'm old fashioned. I will open the belly and see what's going on. If I think I don't trust my fast, or I think something's wrong here beyond. Now, the third point is, seems to be that if you open from the belly, you know, you can enter and see, maybe this is the neck. If it's not the neck, it's not below that, I don't call urology. However, even in shock trauma, when I was there, I had to call urology because otherwise it's complications. Why you didn't call me? You know, otherwise they don't even come, they don't care. But if it's, I had to say yes. By the way, I did a patient, well, I'm doing a patient like that. Because most of the other injuries, the bladder can be repaired, you know, one single layer, two layers, chromic or absorbable suture, that's the way we do, and suprapubic drainage, with the orthopads hate it because they say now that's going to be a top of a repair. They hate you put the suprapubic there, okay, the orthopads. So I don't know what you did in this case, but I just wanted to clarify that most of the bleeding comes from the vein. That's why we do the pre-peritoneal packing, because you know, pre-vesical plexus, the sacral plexus. That's what we do, the peritoneal packing.
Thank you. This is exactly our thinking was the same. So since we didn't have any arterial extravasation in the CT scan, it was a CTA of the pelvis, no extravasation, no arterial extravasation as I showed, and we had no intraperitoneal fluid, so we decided to go just extraperitoneal. Maybe it was a mistake, but this we will see in the next slides. But this is what we decide, and we thought that if the patient will continue to be hemodynamically unstable, we'll do just pelvic packing. We will leave the repair of the bladder, and then we'll go to angio. But if not, if we will see just the bladder, the bleeding is just to the bladder, like we saw in the Foley, so we can take care of it during the extraperitoneal approach. So this is what we decide. I just wanted to show you some slides of like this, the bladder injury scale, and we can see that if the extraperitoneal bladder wall laceration that is bigger than 2 centimeters, we have to repair it, and we have to repair it in the operative approach. So we know that intraperitoneal bladder injury supposed to be repaired operatively, but extraperitoneal, if the patient is stable, so you can just put a Foley and don't repair unless it's complicated lesion. And what is complicated lesion? So complicated lesion or complex extraperitoneal bladder rupture, either bladder neck injury, as mentioned by you, lesion associated with the pelvis ring fracture that we had in this patient, or any vaginal or rectal injuries, which also make it extraperitoneal complex and need a surgical repair. So, as I said, we went on extraperitoneal approach, and we did extraperitoneal exploration in the operating room. So what we saw in the surgery, we opened extraperitoneally. We saw the bladder, the anterior bladder wall is completely torn. So we just repaired it primarily, and most of the bleeding was from the bladder wall, like vessels that were supplying the bladder, and not from the pelvis. The pelvic hematoma itself wasn't that big. We saw a large anterior bladder tear with active bleeding from the bladder wall. And just by repairing the bladder, we also stopped this bleeding. And after we stopped the bleeding and repaired the bladder, so we explored the pelvis, and we saw just a small hematoma, not so big. So we just did hemostasis, put some JP drains, and primary closed the fascia extraperitoneally. 1 second, sorry. After we finished this, we called the orthopedics, and they performed an X-fix to the pelvis.
How could they do that? I have a question because you have a wing fracture. And one of the problems the orthopads have to put these fixators, and my days were the Hoffman, you know, they put it in 10 minutes in the emergency room, the fellows. They don't like to put this because they have to be fixed with the wing, and the wing is fractured. Is any comment about that? They say anything? They say that we're good in rider, you know, we can put anything. Oh, you are not
So
right.
as you can see in this picture, this is the X-fix that they did. So you see they did put also a sacroiliac joint screw. You can see it here in the lateral picture. So they did on the right put a sacroiliac joint, one screw, and the X-fix was from the front, anterior.
Okay.
And you can see our drains in the pelvis and the primary closure of the extraperitoneal. As I said, we didn't do intraperitoneal exploration. Unfortunately, POD post-operative day 4, the patient was doing fine. It was hemodynamically stable, but started to complain of left lower quadrant abdominal pain and some tenderness, not peritoneal. And the inflammatory measurements start to climb. CRP and also white blood count start to trend up. So we went to a CT scan, and on the CT scan, this is on POD post-operative day 4, we saw some air in the mesenterial air, as you can see here, in the mesentery of the sigmoid. So we're not sure what was the etiology, if there was a missed injury that we missed in the first operation because we didn't do intraperitoneal exploration, if there was ischemia because of mesenteric tear, or if one of the screws of the external fixation injured the mesentery or the bowel. Sometimes this can happen also, but we decided to take the patient to the operating room, but since he was completely stable, we did laparoscopy. So in laparoscopy, we saw a hemorrhagic fluid in the pelvis, and we saw the sigmoid colon with mesenteric and ball necrosis without perforation. There was just a necrosis with the compromised blood supply to the sigmoid. The ascending colon on the right side was also with hematoma, but the bowel wall was normal. So we decided not to do anything with this. And we just completed laparoscopic Hartmann procedure. So we resected the sigmoid, and from the opening of the extraction of the preparate, we did the ostomy. So we completed Hartmann procedure laparoscopically. Post-op, the patient tolerate diet. He had the normal cystography, and we did see the Foley after about 1 week from this operation. And on POD 7 from the last operation, orthopedic surgeons say they are not satisfied from the place of the X-fix and the screw, and they want to take the patient back to the operating room. And here I want to ask you if you would let them take the patient again to the operating room or not. It's your patient.
Thank you, Dr. Schwartz. Dr. Kasim, would you like to make your comments first?
I would not. You're winning. When you're sitting on a horse and it's winning, don't get off it.
Thank you, Dr. Kasim. Dr. Hajman, do you have any comments?
Yes. First, yes, I will let orthopedic take the patient to the OR. This is very common that they need to revise the external fixator. We were very close with orthopedics. I understand that other places might work differently. I can tell you what we will do here. We talk every morning, we discuss how the case is going, if it's okay to take the patient to the OR or not. Based on what I see here, I don't see any contraindication to take this patient to the OR. My only concern is, I don't know what happened to the colon, why the colon became necrotic. There is something here that we are missing. Patient like this, I would have considered initially during the initial presentation, maybe to do a sigmoidoscopy to make sure that there is no blood in the rectum, even though there was no blood in the, we have quite a few cases that there is no blood in the digital exam, and after that we find the blood in the rectum, and we proceed with the diversion earlier. So this is the part I am not sure what happened. Was really the screw? This is the screw. Yes, he needs to go back. Even if he has a Hartmann, they need to fix that. So I really don't know what happened with that sigmoid, why the sigmoid became necrotic. That's the thing that is bothering me in the back of my mind. Thank you.
Could I make a comment on that before? When you have a crush injury like this, and it was a massive crush injury from looking at the pelvis itself, you know, to crush the bones like that, and the force that is required is enormous. It is not uncommon to get crush injury in the pelvic area where the blood vessels get crushed and they don't manifest itself immediately. And it is it could be construed as a misinjury, but it really is not. It is the pathology that shows up 3 or 4 days later.
With a normal CTA, I don't know. It's bones don't bend.
We revised the CTA. We haven't revised the CTA of the day 1, yes, from the injury day, and there was nothing on the CT. There was no, let's say, sometimes you can see cloudiness of the mesenteric fat, like some suspicion of blunt injury, and we didn't see. But we did see the hematoma on the right colon during the laparoscopy. So we imagine it was the same mechanism of injury of crush. And this crush probably had some edema and some obstruction of blood vessels, maybe venous even, cause congestion and cause necrosis, like mesenteric ischemia, venous mesenteric ischemia, you know. But we still unsure what was the mechanism. We believe it was the crush.
Okay, can I make a comment? That I'm thinking, you know, I'm old school, I'm 80. So, you know, I wouldn't approach like you did with the extraperitoneal, because think, you enter the belly, at this point, we were not discussing that. We blame, hey, you damn orthopath, you put the screw through. This is your fault, because I have been there, it looked perfect. But no, you are a minimalistic surgeon. These days, everyone wants to do the less minimalistic surgery. So you did the extraperitoneal, so you went blah, blah, blah. And then that is the problem. You know, we have this problem that we have to have ischemia produced by, as you said, other thing I want to remind to the residents and by their life there, that you can have no blush. The absence of blush doesn't rule out active bleeding. Normally, it's a 90% chance that you have blush, that you have active bleeding. But you can have, in some cases, very small, but no blush, and still have active bleeding. So you have to act clinically, you know, something is wrong. You open the belly. That, for me, that solved the problem, but you did an extraperitoneal, now you have to blame somebody. So ischemia, a true fracture, and possible, you know, orthopaths are not famous for being delicate.
And probably I wouldn't have brought the case for this conference if we didn't do the extraperitoneal, because we did
That's
like a simple case of laparotomy.
Como as Cantinflas said, the famous Mexican comment said that I está el detalle. That's what it is. Okay, go ahead.
Dr. Antrag, do you have any comments?
Yes, so I think that, you know, that the crush theory makes sense, because otherwise it's a little puzzling to think how that could have happened. A local injury to the base of the sigmoid mesentery should not cause necrosis of the colon because the collateral circulation is so robust. Shouldn't have happened, but a crush injury can, you can get a contusion of the mesentery and the wall of the bowel, and both of those can undergo necrosis several days later. So I think that makes a lot of sense. The screw theory, I don't quite understand it. There's a right sacroiliac screw, and then the post that was placed into the left iliac crest is not anywhere near the sigmoid colon. I mean, just they would have known if they put the screw in, it broke through and rammed into they would have known. I just don't understand, don't get it. But and then whether or not you would have seen it early on that first day or the second day, if it would have been early enough to see a duskiness of the sigmoid colon, I'm not sure. Although the CT scan, if you look back at it, was there evidence of any poor perfusion of a segment of the colon, the sigmoid, or nothing you can see on the CT? So
No evidence.
Yeah, it's a little bizarre. So in that context, I don't see anything wrong with what you did. Had you gone intraperitoneally, then you'd still have to open and to get access to where the injury was, which wouldn't have been that big a problem because the hematoma would have dissected it open. So it's really, the difference is, whether above or below, the difference is you could have seen the rest of the viscera. But and then as far as the orthopedist, look, if they just want to revise a screw, just don't get into any misadventures. Don't go in there and then send the patient back with a hemipelvectomy like the one patient that do what you said to do, no surprises. And, the patient's stable, fine. I think that's quite all right.
Just a very quick comment. One of the teachings I did to my residents for 30 years in shock trauma is trust no one. Trust no one. If your mother says she loves you, don't trust her. Trust no one. In trauma, you don't trust anybody because the moment you start believing that the orthopaths are very good in my hospital, they never do mistakes. Trust no one. I'm sorry, my doctor from Argentina, but you must be in a good hospital. You trust your orthopath. I never tried them. They usually are not. They can do it. We all can do mistakes. So you have to be put in the back of your mind. It could be anybody. In this case, again, if we open the belly initially, probably we don't be talking about this. If we did now do laparoscopy, you are still minimalistic. If I have a problem and see the CT, probably I go and open the belly. But you keep doing. Maybe they don't pay. They pay more doing laparoscopy in Israel. I don't know. Okay, go ahead.
Okay,
Not in Israel.
Unfortunately, yeah.
Not in Israel, they pay more. Not there.
Yeah. Israel is public medicine. You don't get anything. You don't have any coding or any. You don't collect points or anything. Everything is like you pay the same. The patient paid the same also. Everybody is the same. Everybody gets the same money. So trauma, you won't be rich from doing trauma in Israel, So in any case, but I wish I had your advice before because we let them operate. And then we came the morning later and the patient was about 8 hours in the operating room, bled about 8 packed red blood cells, went out from the operating room with a drop foot, and they did a CT scan, and they demonstrated that the new screw from the left that they put went into the foramina and caused a neurologic injury. And they went back to the operating room to take the screw out and to place another screw. So if you let up, like in this kind of patient, with all the bladder injury, pelvic injury, and now also intestine injury, I would just inspect whatever the orthopedic is doing, probably be there or send the resident to be there and just inform me whatever, if there is any change in plan or any unplanned events. And because we did a lot with this patient, so we want to succeed with him. By the end of the day, the patient was discharged to rehabilitation, still with drop foot. The neurologic injury didn't heal. But I saw him in clinic and he started, he did start some movement of the ankle and the fingers, the toes. So we still have to close his ostomy, his Hartmann procedure, but finally we got a good result also with the pelvic fixation and the bladder repair and also the bowel injury. So that's the case, and thank you for the opportunity to present.
Thank you, Dr. Schwartz. Dr. Antrak, do you have any final comments to make?
Yeah, very interesting case. And, you know, in this case, looking at the x-rays, they did a whole lot more than it's like bait and switch. I mean, they just revised the screw. They just put the plates in and what do they do to the pubic ramus? Nothing. They left they sent them home with the X-Fix?
Yes, yes.
Yeah.
It's off already. Now it's off already, but they sent him with, they didn't took it off. They left it.
So I'm not sure what value you get from, you know, you have the stabilization of the ring with the X-Fix anteriorly and those plates on the iliac crest for what looked like a fracture that was inconsequential, right? They're just the outer, I'm not second guessing orthopedists, but I would want them to educate me. And then why do you need all those screws? What happens if you didn't put them in? You know, what would have been?
So, you know, I don't get into their consideration, like the orthopedics consideration, but if I would know that this is their plan to put that many plates and screws and to take this adventure with this patient that already suffered from bladder injury, bowel injury, and the blood loss. So this is not the patient to go on an adventure with, you know?
Yeah, and any disadvantage of not putting all those screws in has to be a lot more severe than a drop foot. And I don't know. I mean, look, you know, my X-ray didn't look pretty, but I didn't drag my foot and myself. You know, it's okay with me. You know, so that you know, it's a hazard when you have, you know, you call the colleagues in, they look at one aspect of the trauma, the beautiful pelvis, and then but everything else. And you know, there are all the frequent examples all over the world of these cases where this sort of thing can happen. I agree with your approach. You have to be actively involved and be there and, you know, state your concerns. But great case, really interesting, the different options and well pursued.
Thank you.
Thank you, Dr. Antrak. Dr. Hodgman, do you have any final comments?
No, I'm kind of surprised by the amount and the length of those screws. I don't remember seeing anything like this. I came to TAF in 2008. Shortly before my arrival, they have a patient who had a neurologic injury similar to this during a pelvic fixation, which was done by a non-trauma trained orthopedic surgeon. And since then, we haven't had a single one. Again, we're in different places. I'm not telling anyone you deal with the cards that you have been dealt with. Here, we have a very open communication with orthopedics. They would never take the patient to the OR for 8 hours without talking to us. We have a conversation, okay, this is what we are planning to do. And the surgery will last this long.
Orthopedic will say, no, this is just half an hour procedure. This is just 1 hour. And then you find them 8 hours later, still like digging and whatever.
And if somebody will do something like that,
You can
here,
argue
there
with
is a
this,
price to pay.
argue.
Thank you, Dr. Hodgman. Dr. Kasim, would you like to make any final comments?
Dr. Schwartz, it is always fun to wake up 5 in the morning in Portland, Oregon to listen to your cases. You always present good gems. 2 things I learned from you today. 1, when there is a bleeding, go and stop it. Don't rely on angio and all that extraordinary things nowadays surgeons do. You did the right thing. You stopped the patient from bleeding to death, number 1. And then number 2, you successfully repaired everything and then your orthopedic surgeon just screwed it all up because you trusted him and you were in a hurry. What's the rush? You could have waited for a few more days or a week. The patient is not going to die from a fractured pelvis. It can be all done in a timely manner. Those are the two things I learned from you today. Thank you so much for such a wonderful case. And it is worth getting up at 5 in the morning in Portland to listen to you. Thank you.
Thank you.
Thank you, Dr. Kasim. Dr. Rodriguez, do you have any final comments?
Yeah, I wake up every day at 5 o'clock in the morning because I cannot sleep because my wife is much younger than me, unfortunately, and she had to go to work. She's a nurse, so she bought the alarm, so I wake up at 5 o'clock in the morning. But anyway, it's no pleasure, but what can I do? So trust no one, you remember, don't trust her. But anyway, so the point is that here, I think the usual American cliche, Americans always said, oh, that was a wonderful presentation, wonderful case. But this was good, doctor. I'm telling you honestly, it was a good case because mostly Americans said that they don't feel it looks, but they said, always say, that's a wonderful case you present. I enjoy very much your presentation, but anyway, I think the only concerns is again, the fact that was done, I think if they opened the belly, probably, a patient was unstable, it seems like that, maybe could find something or find nothing. Now, I have the similar situation in which orthopath fixed the spine here, the cervical spine, and the patient ended with a esophageal hole in the esophagus. How the hell happened that? But everything is possible, and the Twilight Zone, like the movies, and the Twilight Zone is in trauma. Okay, so good case, good results at the end. The orthopath, I'm sure, I agree that there's going to be Israeli nails. I don't know, I was going to say a joke, but it's religious, nails. But anyway, they are big nails. I haven't seen those big nails, but either. But this is the usual thing, isn't it? They put external fixator first, and then after a few days or whatever, they do the final repair. This seemed like they did almost the final repair, because that's almost the final repair that what they did in the sacral joint, because the only one unfixable yet is the fuse. Good case, doctor.
Muchas gracias. Nos encontraremos en Jerusalén.
Okay, shalom, my friend. Send my report to the Kushner, Kushner was the other guy who wrote a lot of paper with Dr. Jim Moore. Kashuk. Dr. Kashuk.
Kashuk. Yeah, I know him.
Yeah.
He's a vascular. Yeah.
I was doing very typical Israelis. Yeah, no. I said, do what hell I'm telling you. But that's why I say very difficult. Israel is very hard. They always like to argue, and most of the time they are right. Okay, that's it.
Thank you, Dr. Rodriguez. Thank you, Dr. Schwartz. Dr. Tenzin, I hope you had a good time at the meeting today. Do you have any final comments to make?
Yeah, I really enjoyed basically coming from different, I think, countries, and especially I didn't know what was the stepwise, but in my situation, had this patient come because we don't have a designated sort of a trauma surgeon. So if a general surgeon like me, although I do a neurosurgery plus general surgery, I would have followed what Professor Rodriguez was mentioning about. Yes, it is an extraperitoneal bladder injury, but for me, even if laparotomy is negative, I would still sleep well. So probably the first laparotomy would have detected some sort of ischemic changes in the sigmoid colon. So yes, probably I agree the etiology of crush injury, but probably if we had gone a little inside, we would have probably had one laparotomy rather than to undergo a Hartmann's procedure. Otherwise, it is very, very challenging. I think sometimes your evidence medicine actually works. Sometimes going into 1 inch inside little more saves another surgery. But then it's very complicated case. I really enjoyed Dr. Schwartz. I think you made it very, very dramatic and this is something which trauma surgeons like to discuss more and more. So I would look forward for similar discussion in future. So thanks so much.
Thank you.
Thank you, Dr. Tenzing. We hope to see you with us more often. Thank you, Dr. Schwartz, for the excellent case. Thank you, all the panelists.
Thank you, Maya.
Hopefully see you all next Monday.
Bye-bye.
Alon.
Once again. Heart rate.
Thank you, Alon. Good case. Thank you.
100s, and the blood pressure, oscillates.
Congratulations, Antonio. Congratulations.
200 systolic blood pressure as well. He is on true level.
Antonio